webinar. It's my distinct honor to welcome our esteemed speaker, Dr. Balamba, ma'am. She is a renowned obs and gynec with nearly 6 decades of experience and has been an inspiration to many gynecologists in the field across the nation. Dr. Balamba practices at Shalini Hospital in Baraktapura, Hyderabad. Dr. Balamba also had a various member of various organizations, reputed organizations like Indian Medical Association, FOXY, FISOC, and various other things. So today's webinar will cover essential topics in women's health, including PMS management and a non-hormonal solutions and a natural treatment for PCOS. We are thrilled to have Dr. Balamba with us to share her wealth of knowledge and expertise. Over to you, ma'am, and I am sure the audience is eager as I am here to hear your insights.
Thank you, Vikas. Thanks a lot. Can I have the slides on now?
Just sure. Just wait for a second. There.
Go back. Yeah. So today we are going to talk about the premenstrual syndrome and also the premenstrual dysphoric disorder. So how are we going to treat it and what exactly is a premenstrual syndrome and a premenstrual dysphoric disorder, how it affects the lives of women and what we can do about it to alleviate the suffering by these women. Next slide. Next slide, please, Vikas. Yeah. What is premenstrual syndrome? It's a cyclical phenomenon characterized by a combination of somatic symptoms and psychological symptoms. I am sure all of us have at some time or the other seen these symptoms where patients come and complain to us from younger to older generation. And they tell us that just before periods, they have lots of problems, especially, just before the periods, they have pain in the breast, they have mood changes, they become very irritable, and then, the family members are getting upset because they are having these problems. So how do we classify, how do we say that it is a premenstrual syndrome? Does it occur right from menarche? No, it doesn't occur from menarche itself, but it starts around 20 years of age perhaps, and more so about 30 to 40 years. And the severe form where, there are lots of psychological symptoms, we call it a premenstrual dysphoric disorder because there is an overlaying of psychiatric problems also in these women. Now, 43 to 8% of women in India have been reported with the PMS, that is premenstrual syndrome, 43%, and the severe form, 8%, that is a premenstrual dysphoric disorder. Now, a study conducted at Belagavi, Karnataka, among 420 college girls found that 86% of the college-going girls have these PMS symptoms. Now, the stress levels have increased in our younger women these days, both from study point of view as well as career point of view. And they do have a lot of stress, and that this stress alter anything in them which causes this increase in the premenstrual syndrome we'll have to think about. Next. Now, most commonly reported symptoms, what are they? Like I said, they have pain in the abdomen, lower abdomen especially. Sometimes it can be all over the abdomen and general aches and pains. They become very irritable, they're depressed, unnecessarily they'll start crying. For nothing, they'll start crying. And then bloating in the abdomen and breast tenderness, the mastalgia. They get angry for nothing. And then they have nausea, vomiting, and they feel very fatigued and they don't feel like doing anything, And then they don't even feel like studying even if there are exams. So the decreased concentration. And of course, mood swings. Sometimes they're very happy. Immediately they're depressed also. Then of course, headache, anxiety, and they can't sleep. And they may either have increased appetite or decreased appetite. Either way, These symptoms can be very severe, and not all women will have all these symptoms. Some may have some symptoms, some may have all these symptoms, but the premenstrual syndrome, we will have to diagnose depending upon these symptoms which they are complaining. And especially in younger girls, the mothers will tell us, just before the periods, she is becoming irritable, she is yelling at everybody, and we don't know how to control her. And these are the symptoms which you'll have to make a note of and then think about it and find out why she is having these symptoms and ask her, is it occurring only this cycle? Has it been occurring before this also? Is it continuously since 3 cycles or more? Or it has just started in this cycle, particular cycle. So unless we record all these, and in the conversation, we'll have to find out gently from the girl whether there is any problem, any, what should I say, something, some incidents which is triggering these problems in her. That also we'll have to find out because we'll have to rule out a PMDD also in these girls. Next. Now, the classification according to the Royal College of Obstetricians is, it depends upon whether they have cyclical problems and then, they have symptom-free week, no influence on quality of life. Because many girls now say they don't want to go to the college during the periods or the school. And some of the women, they don't want to go and work also during this period, just before periods and during periods. So that is why, many of us are asking for menstruation leave also, isn't it? All the feminists are asking for it. And then, the day of menstrual cycle, once the periods start, they may disappear. So is it happening or not? So if it is only just before menses and then it gets resolved during menses, then counseling and reassurance is required and no active treatment is important at all. This is how the Royal College of Obstetricians and Gynecologists, they describe these symptoms. And the second group is cyclical symptoms relieved by menstruation, and there is an affectation of quality of life. The previous group didn't have any affectation of the quality of life, but here there is a quality of life affectation, and consider an alternative approach to treatment. So we will have to treat them because their quality of life is suffering because they are not able to perform their daily work. The quality of life is suffering. And then, the third group is where they have existing non-menstrual condition also during periods, before periods, or throughout also they may have these problems. And the premenstrual exacerbation only happens. Then, we'll have to treat them definitely, and we'll have to assess their psychiatric condition also. We may have to refer them to a psychiatric also. Now, the fourth group, where the premenstrual disorder with absent menstruation, they don't have menses, but they have these symptoms. So this is as a core premenstrual disorder because this can happen even in PCOS also, where they have periods of amenorrhea, where there is mood swings, there are alterations of the hormonal milieu in their bodies. There also they can have these sort of symptoms. Then the fifth group is where progesterone induced. We do find, even pregnant women who are given with the recurrent pregnancy loss, where we put them on our after induction of ovulation or after ARC treatment, where they are loaded with progesterones, they become depressed, they become irritable, they cry for no reason at all. So we all know that progesterone can induce depression in these women. So it can be there. And this also can be a problem because after ovulation only this occurs. Suppose the woman doesn't have any ovulation, she is having an anovulatory cycle, she may not have these symptoms. So that also we'll have to find out. So then, we'll have to alternate progesterone treatment where, the progesterone doesn't affect their psyche, that we have to find. Now, the sixth group is non-cyclical, no symptom-free week, forever they're depressed, they're having a problem whether they have a menstruation, no other not having menstruation. Sometimes, even in menopause, they may have these sort of symptoms. And then, we'll have to think of an underlying depressive psychiatric disorder also. And then, we may have to refer them to a psychiatrist. Next. So what is the etiology? We don't know the exact etiology. The various theories are hormonal fluctuations. But what we know is that progesterone may be linked to it, along with the estrogen not being in surplus. During the luteal phase, the estrogen is low, progesterone is high. But then when there is progesterone deficiency also, there can be a problem. So what exactly happens, no one knows. But we all know that progesterone can induce this sort of problems. And again, what they have found is there is high prolactin levels, which is associated with low estrogen levels. They can cause depressive symptoms, and high prolactin levels also associated with low progesterone levels. It may cause anxiety and irritability also. So does prolactin has any role in this PMS? That again we'll have to investigate. Next. So there is, like I said, lots of theories. So the mood hormone, serotonin, what happens to serotonin? As well as the gamma, GABA, the gamma butyric acid and serotonin and catecholamine, all these things, do they also have a problem? That also we'll have to think of. Now, pre-existing, what I have found is definitely SSRI treatments, usually improves the moods in all these girls. So there can be some problem with serotonin deficiency with increased progesterone sensitivity, which is also linked to PMS. So according to molecular biology studies, estrogen causes, decreased estrogen causes hypothalamus to release norepinephrine, which triggers a decline in acetylcholine, dopamine, and serotonin. That leads to insomnia, fatigue, depression, which are common symptoms of PMDD and PMS. So there is a problem from the hypothalamus, which induces this premenstrual syndrome. Next. So the other causes include glucose metabolism alterations, abnormal hypothalamo-pituitary adrenal axis function, insulin resistance, certain nutritional electrolyte deficiencies. Of course, there can be genetic factors also, because we do find PMS among siblings, sisters. Maybe the mother also had a similar symptom. All these things in the history we'll have to find out. And increased prostaglandin can also trigger many of these symptoms of PMS. Now, what about the dietary and lifestyle factors? Smoking, alcohol consumption, caffeine beverages, and less habitual exercise, poor sleep quality, and fat-rich diets are significantly associated with PMS. Now, what about the stress? I already spoke about stress amplifies the sympathetic activity. So naturally, the pain also increases and the intensity of the uterine contraction also increases. Next. So what happens if there is PMS? Naturally, the quality of life is affected because the child is bunking school or the college, or you are not going for work. See, your work also gets affected. In the workplace also, people may look down upon you. So that also will, occupational productivity comes down. So naturally, people will start thinking, why is this woman doing this during her menses? So that becomes a talking point, a gossiping point, and which can affect their productivity in the office also. And of course, they have to visit the clinics because they don't know what is happening, why this is happening. So they want to come and they want to have a permanent resolution of these things. So is it possible to permanently resolve this symptom? That the doctor has to answer these people. So we have to prepare with all these answers when they are querying us. So due to high disease burden, the right diagnosis and management of the condition becomes crucial. Next. So how do we diagnose? The ACOG has again another criteria, more than one of the following things. Symptoms, if they are present, then we'll have to diagnose as premenstrual syndrome. And we have to see whether these are present in the previous 3 cycles, not in the present cycle alone. So the affective symptoms can be angry outbursts, anxiety, confusion, depression, irritability, social withdrawal, and the somatic symptoms like abdominal bloating. Many people tell us, just before periods, they put on weight, 2 or 3 kgs, and their legs also swell, the abdomen bloats, and then the breasts also become bloated, bigger, and there is tenderness and swelling, and then headache and joint and muscle pain, swelling of extremities, like I said, and the weight gain, like I was telling you. So these symptoms being consistent with PMS, symptoms like I said, should occur consistently in the previous 3 cycles. And it should occur only during the luteal phase, that is after ovulation occurs, after mid-cycle. This has to happen. And then, it should disappear once the menstruation starts. And the negative impact on patients' function and lifestyle is very, very important. You ask the girls whether they are going to school during the menses, just before the menses, many of them will say that they are bunking the school. And the parents are worried about it. In these days of high competition, for higher education, the parents are worried because the girls are not going to attend the college or school. So that we will have to explain to the parents also. This is a common problem and there is a management schedule for them and the parents need not worry about. Next. So how do we manage? So the management, it can be hormonal contraceptives, which prevents ovulation. So naturally, the progesterone rise does not occur. But then, the hormones themselves can have some side effects. And the most important being deep vein thrombosis. Of course, the low dose, with the low dose estrogen pills, there can be spotting, a breakthrough bleeding, what we call. Then antidepressants, they can also cause a sleep problem, decrease libido, and the woman is forever feeling sleepy. Of course, painkillers you can give, but painkillers come with their own problems. Like, it can affect the kidneys, isn't it? It's a renal function. So you can't be forever prescribing any sides. Diuretics, maybe, but then you'll have to be very careful so that you don't induce any electrolyte imbalance. And the last resort is gonadotropin releasing hormone. I don't think any gynecologist will do gonadotropin releasing hormone for PMS. Next. Next slide. So the first line treatment will be, according to the RCOG, it is the exercise, cognitive behavior, that is lifestyle changes. Exercise, cognitive behavioral therapy, vitamin B6, combined new generation pill, cyclically or continuously, where you are preventing ovulation, that's all. And continuous or luteal phase, low dose SSRIs, like I said, escitalopram or sertraline also. According to me, sertraline works much better than escitalopram. The second line, of course, estrogen or patches, to increase the estrogen. But I don't think any of us are using these micronized progesterones orally. And the higher doses of SSRIs continuously or luteal phase, like again, the escitalopram or citalopram. For this, again, we should consult a psychiatrist before we start prescribing all these antipsychotic drugs. The third line, of course, according to RCOG, is GNR Janalox with add back HRT, but I don't think our women usually need this sort of treatment. And I don't know what surgical treatment we can give them. Though the Royal College says surgical treatment plus HRT, why should we remove the ovaries just to treat PMS when we have so many other avenues open to us? So I don't think, this fourth line doesn't works out for us at all. Next. Now, along with the PMS, the cyclical mastalgia also has to be managed because in these days, where there is increased awareness of breast malignancy, a woman has pain in the breast, she thinks she has breast cancer. So we will have to explain to them not all painful breasts are malignant. And in fact, in malignancy, pain is the last thing to occur. The cyclical mastalgia, which occurs only just before periods, and once the menstruation starts, it disappears. But for some women, it can be continuous. It can be only on unilateral breast. It need not be on both breasts also. So all these things will have to take interest in and then ask them questions as to when it occurs, what happens, how painful is the condition, because we'll have to manage this mastalgia and find out whether it is the PMS or is there any infection, mastitis, breast abscess, anything can happen, isn't it? Or maybe even a breast malignancy. So all these things we'll have to find out. And one more thing which we have to remember is the fibrocystic change in breast can also cause mastalgia, which may not be in relation to the menstrual cycle at all. It is throughout the cycle she has pain because of the fibrocystic chain. And why are we interested in fibrocystic chain? It can be a pre-malignant condition. So we'll have to be very careful when we are clinically palpating the breast, and also to rule out fibrocystic change in the breast when they are complaining of mastalgia. So we should find out whether it has any relation to menstrual cycle, whether it is occurring only after mid-cycle, is it manifests around 30 years of age. Usually in younger women, it may not occur. But after 30, yes, it can definitely occur. Usually bilateral and diffuse, but can be unilateral very rarely. Often worse in upper outer breast and can radiate to the axillary region also. And in fact, if there is a axillary tail of breast present, then that also can be painful, which we'll have to reassure the woman about, because many women come and think, there is some swelling in the axilla, but they don't know that it is an extension of the breast, which they are having, which also manifests all the symptoms of breast. Again, the exact etiology remains undefined, why it occurs, but we all know when we are using the intrauterine progestation system, Mirena placement, there also it can induce pain in the breast. That means the progesterone can cause pain in the breast. And can there be an increased estrogen level which can stimulate the ductal elements of breast? And then, the decrease in progesterone, stimulation of stroma, concurrent increase in prolactin, which we were talking about in PMS symptoms, causing increased ductal secretion, which also can contribute towards pain and swelling, and association of cyclic mastalgia with hormonal therapy. Like I said, if you are giving only estrogen supplementation, especially in premenstrual, postmenopausal women, that also can cause pain in the breast. And in premature ovarian insufficiency, when you are putting them on hormones, where it is a hormone replacement therapy, unlike hormone therapy in postmenopausal women, there also there can be mastalgia. So we'll have to take history very carefully and find out what are all the medication that she is using. Next. So features, what are the things that we'll have to find out? So cyclical breast pain, it starts 2 weeks before menses and improves after menses starts. It is dull, heavy, achy, and it is bilateral and poorly localized and extends to axil also, like I said, because there can be an axillary tail of spines. Then non-cyclical breast pain, it is not related to menstrual cycle. It is constant or intermittent. It can be unilateral, it can be variable. Here, you'll have to think of fibrocystic change. And then chest wall pain, it is completely different. It's a muscular pain. It's a muscular pain. Maybe, the woman lifted something from the attic, or she lifted some heavy weight. And sometimes, where women are doing the cardio exercises by lifting weights, in the gym, that also can cause this sort of chest wall pain. So taking a proper history is very, very important. Next. So what is the treatment? A detailed history, like I said, and physical exam is first and most important. If you palpate, always clinical examination of breast by a medical person is much better than a self-palpation. That is why, now all the gynecologists have started palpating the breast in all the women who come to us. Like, we always put in a speculum and examine the cervix and look at the cervix, for any changes. And like they say, pap smear is mandatory now, because the oncology committee of FOPSI also is telling us to examine and to look for HPV infection also. So these are the things, which we'll have to look at. And the same way we are looking at the breast also, but because now we know breast malignancy has taken over from cancer of cervix, isn't it? So a mass palpated, and believe me, even younger women in our country are having breast malignancies. We should mandatorily palpate breasts of all our women patients who are coming to us for other reasons also. So methodically, you palpate with your palm, you go circumferentially, and then, around the areola, and then, just pass your hand over the breast, and you will be able to feel a mass and find out what sort of a mass it is. whether the skin is fixed over it, then palpate the axilla also. So all these things are very, very important. So you have to look at the exact cause, why the woman is having pain. So patient presents with breast pain, first perform physical exam. If there is a mass, the management is completely different. If the woman is younger than 40 years, you go for a sonomammogram. Make sure that it is not a malignancy. And if it is a malignancy, the management is completely different. Then no mass palpated, there is a focal pain or a diffuse pain. That again, you'll have to think of. If there is a focal pain, rule out a breast abscess first. And then patient younger than 30 years, targeted sonography. If it's normal, forget about it. Patient 30 years or older, Now even in US, 30 years and older are not being done digital mammography because of the exposure. Even here, over 40 years only, we subject them to a digital mammography. And especially in postmenopausal women, where the breasts become very dense, digital mammography doesn't work. You will have to go for a high resolution ultrasound scan to make out any malignant change, any mass which has a malignant potential. So then, if it is normal, then you reassure the patient. And then, if there is a abscess, you treat the abscess. And if there is nothing and only she is having cyclical pain, reassure her. And the treatment of PMS itself can also relieve the mastalgia. The diffuse pain, patient does not have risk factors, there is no family history, no imaging indicated, provide reassurance. Like I said, persistent pain, again, treat it. Patient has risk factors or over 40 years, consider mammography. Just to reassure the patient, if your clinical palpation does not even reveal a mass, you have to get a mammogram done so that the patient is reassured and you're also reassured, because there can be a small little mass also which can be malignant, which will be revealed only by high resolution ultrasound scan. Next. So how do we manage? Like I said, if there is nothing, reassurance, lifestyle advice, discharge. What is the lifestyle advantage? Before menses, you will have to tell them to wear a tight fitting bra which fits properly and not compresses the breast or causes pain in the breast. And then, patient requires treatment. You will have to look at what exactly is the cause. You can use NSAIDs. Tamoxifen, I don't think any of us are using tamoxifen in our country at least, though it is recommended 10 milligrams, for 3 months daily. Only in the post-breast malignancy where the ERPR are positive, the patients are put on tamoxifen. Originally, it used to be for 5 years. Now they have extended it up to 10 years also. So tamoxifen, we know, is anti-estrogen. It's a SERM. So at least I have not tried it, because if anybody has tried tamoxifen for mastalgia, they can inform me. Danazol, of course, is a no-no thing. We never use danazol, though the surgeons prescribe danazol in mastalgia when women go to them. Glucerin, again, we don't use at all. Musculoskeletal pain, the treatment is completely different. And then, we can use the same, whatever we are treating for premenstrual syndrome, the same treatment also controls the cyclical mastalgia. Next. Next. So the treatment, like I said, reassurance, and we don't use any of these things, but we use, of course, the evening primrose oil. Even for mastalgia, it works very well, so that we can try. Next. So what are the treatment options available for management of PMS and mastalgia? They come often with significant side effects, like, whatever treatment has been shown so far, I don't think any of us are using those drugs, because they can cause a lot of problem. Tamoxifen especially, it can cause lot of dryness in the vagina, though it is not going to cause any problem, but it can cause endometrial hyperplasia. So we do not want to give tamoxifen, because that is what, when women with ERPR positive breast malignancy are put on tamoxifen, we are always looking at the endometrial thickness and whether there is increased vascularity, because it can induce endometrial hyperplasia with ADPI and malignancy also. So what we are using nowadays is evening primrose oil in synergy with tocotrienol. And what is tocotrienol? How do they act? Let us find out. Next. So evening primrose oil is it is made from seeds of evening primrose plant. It comprises of linoleic acid and gamma linoleic acid. Both have anti-inflammatory and pain relieving properties because they increase the PGE1, so that the pain release is improved and PGE2 levels go down. So EPO contains linoleic acid, which becomes gamma linoleic acid. It restores the balance and its metabolism reduces the breast pain. So mastalgia comes down. And then, GLA and its metabolites, which causes breast tissue abnormally sensitive to normal hormone levels, they are, once it is given, they naturally decrease the sensitivity. And then it is a precursor of PGE1. So there is increase in PGE1 levels, which are anti-inflammatory. So it decreases pro-inflammatory eicosanoids. And then, the cytokines like human necrosis factor, alpha, interleukin 1 beta and interleukin 6 are decreased. So naturally, they will reduce the pain. And then it's suppression of the, if there is a suppression effect on prolactin also. So naturally, there will be relief of the mastalgia as well as the symptoms of PMS. So it improves the symptoms, and the supplementation is vitamin A in alleviating symptoms of PMS. Like vitamin, all know is, of course, we have reduced it because we know increased vitamin E can be a toxic thing also. It can cause toxicity. So we use it for a particular period only and not forever. And of course, vitamin B6 is a factor because sometime before the evening primrose oil was introduced, we were using only vitamin B6 for mastalgia, which is a factor which increases the serotonin and dopamine synthesis. And many studies suggested a beneficial effect of vitamin B6 on PMS symptoms. Next. So tocotrienol is from vitamin E beyond tocopherols because vitamin E has 8 different structurally related compounds, out of which, tocotrienol is the best. It is more potent antioxidant, 40 to 60 times better potency due to their better distribution in the cell membrane lipid layers. So a better free radical scavenging ability. It's a better antioxidant. So US FDA has classified tocotrienol as generally recognized as safe. Generally recognized as safe, GRAS. Next. So this is a real world study, which has been conducted by UNS, and Dr. Manish Garg was part of it. And 105 doctors were involved in it with 510 patients. So each with 2 patients, where they found when they used EPO, tocotrienol and vitamin B6, where they administered 3 months, they found the PMS score came down by 61%. And then the visual acute syndrome, visual analog signs, it became 75.2% reduction, and change in baseline breast pain score also has reduced by 82.5%. So this is a real world study which was done in our country. And there were 105 gynecologists involved in this study from all over India. Next. The efficacy of combination of EPO and vitamin E, vitamin B6, when you look at the randomized controlled trials, with the placebo, you find that there is an increased improvement with total premenstrual daily symptom score and was found to be effective in treatment of PMS. This is a randomized controlled study. Next. Next. So these are so many trials, which have shown that the evening primrose oil and vitamin E together can control the PMS symptoms. These are various studies: double-blind trial, randomized controlled trial, placebo-controlled trial, placebo randomized controlled trial, and randomized double-blind placebo, where there's a crossover also. All these studies have shown us that evening primrose oil in PMS is really very good and improves the symptoms tremendously. Next. So it is a first line treatment even for cyclical mastalgia. Like I said, you take the proper history and then family history of breast malignancy also. And more than 35 years, like I said, only sonomammogram. And then if it is normal, reassure. And then persisting pain, document. There, when does the pain occur? The visual analog scale is also, you mark it. And evening primrose oil or simple analgesics, you can give them. So 40 to 60% of patients will find relief. If there is no relief, then we still don't give danazol, pardon me, because we don't use danazol for mastalgia at all. At least the gynecologists don't use, though the surgeons do prescribe danazol. Next. So what do the textbooks say? Because you see, the textbooks always are going to write about the articles which have been published. All the randomized control trials, everything is, concentrated, and then only they come into the textbook. So according to Shaw's textbook, EPO diverts harmful PGE2 to PGE1 and replenishes the CNS PGE1, suppresses irritability and depression, as well as reduces fluid retention and mastalgia. Again, Menzel and Webster's benign disorders and diseases of breast, they also say EP was moderate efficacy and good safety profile because it is a nutraceutical, it has a safety profile. So it's a first line treatment option for management of mastalgia. Again, essentials of breast surgery, it also shows there's a high responsive rate with EPO and significant improvement, pain and, very minimal adverse events. So it is recommended as a first line therapy. Next. So this is the effectiveness, EPO, where you give combination, you find a superior efficacy compared to just plain EPO or vitamin E or a placebo. Next. So again, EPO plus vitamin E for the treatment of mastalgia, clinical evidence, 90.63% patients reported complete resolution with only EPO and vitamin E, thus proving a quite efficient method of treating mastalgia instead of giving NSAIDs. Thank you very much. Should we take any questions now or shall we wait till we finish the next talk? Because
So,
I
ma'am,
think
we
at
can
the
do
end we
both
can
the talks. Yeah, at the end we can take the Q&A, ma'am. Let's finish both the talks.
okay, sure. Go ahead. Go ahead with the next
Sure,
presentation.
ma'am. Just give me a second.
Okay. Now, all of us know about PCOS management, and now with all the new guidelines, by Helen Mead from Monash University, where all the experts from all over globe have been contributing to these new guidelines. I'm sure all of us have gone through these guidelines. So a natural, effective and safe solution for empowering PCOS management, all of us are looking at. And PCOS is really becoming a big burden with increasing obesity and increasing diabetes in our country. So we have to look at how we are going to solve this problem of polycystic ovary syndrome. And we all know that the PCOS, the name itself is a misnomer because it's only an effect and not the cause of all the problems of polycystic ovarian syndrome. And funnily, though there is a lot of insulin resistance, nobody mentions insulin resistance into the etiology, when we are talking about. I don't know why. But I think, we have to bring in that also because almost 60% of polycystic ovary syndrome patients will have insulin resistance. And we also know there is a corollary polycystic syndrome like polycystic ovary syndrome in women, in males also, where there is a metabolic dysfunction because of alteration of all these LH stimulation. And that is what we have to look at. It's the most common endocrine and metabolic disorder. And the most important thing is the metabolic dysfunction associated with polycystic ovary syndrome, which in the long run affects the woman. Because the polycystic ovarian syndrome is not only during the reproductive age, but it goes beyond that. That we'll have to understand. It impacts women across lifespan from adolescence to postmenopause. And the prevalence rate is quite high among Indian women, especially the South Asian women. There is a genetic predisposition. It is saying it's 11%, but if you look at the clinic Our clinic patients, it is much more than that. And the etiology is very complex. We don't know what exactly it causes. It's because of polycystic ovarian syndrome. Though we know what exactly happens in polycystic ovarian syndrome. Actually, there is a group of doctors who want to change this name also from polycystic ovarian syndrome because it is not the cause. It is complex, like I said, genetic and lifestyle factors. And in fact, it is a polygenic in origin. And the lifestyle factors, that is the epigenetic factors, are altering this occurrence much more. And the clinical presentation is heterogeneous because these women can present with cosmetic problems, reproductive problems, metabolic problems, and because of obesity, which is associated with it, or obesity causing the polycystic ovarian syndrome, psychological features like depression, because they have periods of amenorrhea, they are not able to conceive, they have various cosmetic problems, then they may develop diabetes, hypertension, and the metabolic syndrome where there is increase of visceral fat, the waist-hip ratio, all and the increased triglycerides, which is defined as metabolic syndrome by WHO. All these can occur in these women. Next. So what is the pathophysiology? The pathophysiology, like I said, the most important is insulin resistance and hyperandrogenism. You see, the insulin resistance increases with hyperandrogenism, and the insulin resistance increases with hyperandrogenism. Both are acting together, one against the other. And hormonal derangements are the major underlying pathophysiology. So what happens? There is an increased pulse of GnRH. The pulsatility increases. It is chronic, normally the GnRH has to occur pulsatility. The pulsatility has to be there. So it is not continuous. But if there is an increased pulsatility in PCOS, like you see in this condition, there can be problem because, the cholesterol is changed into androstenedione, and then it becomes testosterone in the thicker cells. In the granulosa cells, what happens? The androstenedione is converted into estrone by aromatase, and then, estradiol, it can be converted into estradiol also. And because the visceral fat increases, there is a lot of free fatty acids, which also increases the insulin resistance in PCOS. So there is multiple physiological problems going on in PCOS, which causes insulin resistance and hyperandrogenism. And because there is an increase in insulin resistance, the SHBG also comes down. So more and more testosterone is released. There is free testosterone causing all the cosmetic problems. So there is an increased LH stimulation. And then, like I said, there is increased pulsatility. And once the androgen increases, the insulin resistance increases further. So these are all problems. They are all upregulated. So GnRH should be controlled. And that is why, in women who come to us early, who are not requiring any reproductive, not facing reproductive problems, or who want to postpone their periods, the sheet anchor of treatment is oral contraceptive pills cyclically, so that, they have regular cycles, so that the eggs are also not damaged. You have still some egg pool, so that, further reproduction can be managed. So these are all the things which you will have to think of, because once you give oral contraceptive pills, the LH pulsatility automatically comes down. Next. So what are the signs and symptoms? Difficult, like I said, infertility. And there is an increase in utilizing hormones, so naturally there is no egg release. Then pigmentation, acanthosis nigricans, acne, decreased follicle stimulating hormone, hirsutism. And then, because the eggs are not being released, there is polycystic ovaries, weight gain or difficulty in losing weight, mood swings. And then, even if there can be menstrual pain, irregular periods, naturally periods of amenorrhea, followed by these prolonged bleeding also. So there can be an abnormal uterine bleeding. And what they have not mentioned is metabolic syndrome. And apart from metabolic syndrome, there are two things which we have to think of, because the increased estrogen is there. Endometrial hyperplasia, atypia, and endometrial cancer also can be a problem of PCOS. Next. So if in untreated, like I said, it causes metabolic dysfunction. So naturally, when there is metabolic dysfunction, there is an increase of 1.7% increased risk of cardiovascular disease and infertility. Of course, we all know 70 to 80% of PCOS women will have infertility. It depends upon the phenotype also. There is a phenotype of PCOS where they're regularly ovulating. They may not find it difficult to conceive, but the other symptoms will persist. Like they can go in for metabolic dysfunction also. Next. So the holistic management PCOS is by addressing the underlying pathophysiology. But the sheet anchor of the treatment in PCOS is lifestyle management. Any other problem, any other treatment, has to be first, after mentioning lifestyle management, only should be mentioned. So should be the priority which can help the correction of PCOS features and prevent and reduce the risk of PCOS associated complications. So reducing the weight, reducing the visceral fat, and improving the insulin action are the sheet anchor of management of PCOS. So how do we do it? By reducing weight. So strict diet and exercise are mandatory, and this has to be lifelong in these women, apart from using medication to decrease the insulin resistance. Next. So what about berberine? This is the newest, latest thing which is being used in PCOS management. This is again from a plant. It is isoquinoline derivative alkaloid found in various herbs of berberry species. It is also known as Daru Haridra in the Ayurveda. See, in Ayurveda, various plants were being used, and most of us don't even know about this. The fruit of the berberry plant, it contains berberine, was used for blood purifying properties as early as 650 BC, which is recorded. And it was first isolated and characterized in 1830. And after extensive research, it has emerged as a natural remedy for various ailments, including digestive, cardiovascular, neurological, metabolic, and endocrine diseases. It has gained popularity as a potential treatment option for PCOS in English countries because it decreases the insulin resistance. So it has been compared with metformin. We all know that metformin causes so many side effects. Though it's a very good drug, it's a cheap drug, but it has lots of side effects. And once you prescribe metformin, even the chemist will tell the patient, when they go to purchase the drug, are you having diabetes? So the parents are worried about adolescents, especially going in for metformin management, as also the combined oral contraceptive pills. Next. So berberine, it is multi-target, multi-path plant extract treatment for PCOS. So what does it do? It activates the AMP pathway. So the GLUT4 we all know is a transporter channel into cell membrane. It translocates GLUT4 into cell membrane. So they increase glucose transport into cells and uptake. The cells will take the glucose and there is increased glucose metabolism. That is the reason, even in diabetes, we tell women or the patients, diabetic patients, to take a walk at least for 10 minutes after each meal so that the muscle can take up the glucose. And it increases insulin receptor expression. So naturally, the sensitivity is improved, more glucose utilization after. And it suppresses the androgen receptor signaling because the insulin resistance is gone down. So naturally, it suppresses the androgen receptor signaling. So naturally, it inhibits binding of androgen to androgen receptor. So naturally, the hyperandrogenemia also comes down. So there are two things, like I said, these two are combined, isn't it? Insulin resistance and hyperandrogenemia are together in PCOS. So you reduce one, the other also automatically comes down. Next. So the clinical study on short-term effect of berberine in comparison to metformin, what they found is the HOMA-IR, the fasting blood sugar, the sex hormone binding globulin, and free androgen index, and the weight, everything, almost it is similar. In fact, in certain things, berberine acts much better than metformin. So berberine showed similar effects as compared to metformin in reducing insulin resistance, hyperandrogenemia, and body weight. Next. Again, another study, effect of berberine, myoinositol and metformin in women with PCOS. We'll talk about inositols also a little bit. And berberine showed a similar improvement to metformin after 3 months of treatment in the terms of insulin resistance, blood glucose, hyperandrogenemia, body composition of parameters, lipid parameters. The weight may not come down, but the visceral fat, it does come down. The visceral lipid also comes down. So berberine was associated with similar improvement in various outcomes as compared to metformin. Next. So again, this another study confirmed positive effects of berberine supplementation even with in women with PCOS with a high safety profile. Well, it's a nutraceutical, so the side effects are very, very less. So it has a effect on dermatological, that is a cosmetic problem, metabolic problems. So everything is comparative. And here, if you look at, the control patients, if you look at the control patients, berberine has improved the symptoms like, regular menses have resumed and normalization of ovaries anatomy, that is the PCOS has disappeared, reduction in the presence of acne, and then improvement of modified Ferry-Gallman score, that is the hirsutism. Next. So this is again, for the women with polycystic ovaries and IVF, the berberine and metformin treatments prior to IVF improved the pregnancy outcome by normalizing the clinical, endocrine, and metabolic parameters. And berberine is supposed to have more pronounced therapeutic effect and achieve more live births and fewer side effects than metformin. Next. Again, the effect of berberine on reproduction and metabolism in women with PCOS, a systematic review and meta-analysis. So they have compared lots of studies. 12 RCTs were included, and they found that berberine appeared to be more efficacious for improving dyslipidemia and decreasing androgen levels and LH-FSH ratio in women with PCOS when compared to metformin. So the postprandial glucose, fasting insulin, HOMA-IR, everything, has improved. And the total testosterone significantly decreased, SHBG significant improvement it raised, and obesity, waist circumference has come down, and waist to hip ratio also has come down. Next. And then PCOS insulin resistance, again, this is another study which shows there is a berberine showed a promising prospect in treating PCOS with insulin resistance compared to metformin. And another study, same again, it also shows that there is an improvement with berberine in PCOS about the insulin resistance and as well as the visceral adipose tissue in the absence of weight loss and improved insulin sensitivity, quite like metformin. So berberine is safe, effective, and a promising molecule in management of PCOS, though lots of studies are showing this. It's a safe, novel dietary supplement, helpful in treatment strategy of PCOS. So safety profile, adverse effects, don't think that there are no adverse effects. There can be adverse effects like anorexia, loss of appetite. See, any drug which improves the insulin resistance will have some problem like bloating, nausea, vomiting, like metformin, But it has a better safety profile than metformin and low incidence of GI side effects. No adverse effects. Metformin, when it is given, you have to supplement B12 because it brings down the B12. And naturally, when B12 is brought down, the homocysteine levels are going to. So you will have to add B12 also when you are prescribing metformin. Whereas, with berberine, it may not happen. It's well tolerated with a favorable safety profile. Next. So in a nutshell, it reduces insulin resistance, reduces inflammation, promotes weight loss, improves abnormal lipid levels, improves hormonal derangement, and reduces the androgen levels. So there is a multiple targeted effect. Next.
So Balamba ma'am, we should continue with minoxidil also?
Yeah. If you can. If there's time, we'll continue.
Sure.
So then, about the inositols, we all know inositols is a type of sugar. And what about the use of MI and DCI, that is myoinositol and DCI in the management of PCOS? 40:1, See, one thing we have to understand is in each tissue, this ratio is different. But in blood, normally it is 40:1. And myoinositol is converted into D-keroinositol by epimerase, that is the enzyme which converts. And both have different actions on glucose metabolism. Next slide. So how do they act? The myoinositol is important because it improves the action of FSH. So naturally it acts on the granulosa cell. So the egg quality will improve and the estrogen will improve. Whereas the D-keroinositol, which is converted by epimerase from myoinositol, it acts on the theca cell and produces more androgens, and androstenedione is produced here, and which can get converted into estrogen. So it acts as an aromatase inhibitor and participates in androgen production, and MI increases the FSH activity. Next. So in glucose metabolism, what happens? The myoinositol increases glucose uptake and conversion of glucose into glycogen. Whereas the DCI promotes glycogen synthesis, increases the breakdown of glucose, and it increases the insulin resistance so that more glucose is utilized. Next. So what happens in PCOS to MI and DCI ratio? Especially in ovaries, there is a paradox. We call it a ovarian paradox. In PCOS, everywhere in the body, there is insulin resistance. But in ovary, there is no insulin resistance. So what happens? The myoinositol gets converted into DCI because the epimerase depends upon insulin, because there is no insulin in resistance in ovaries. More and more myoinositol is getting converted to D-keroinositol. So what happens? The D-keroinositol is acting on theca cells, producing more androgens. So the myoinositol level goes down, the FSH receptors will go down, the egg quality suffers, and because there is more and more androgens which are getting into the bloodstream and periphery, they will become converted into, because of the androgens, can convert it peripherally into estrone in the fat tissue because of aromatase. So that is the problem which is happening in PCOS women, So there is a myoinositol deficiency which causes a negative effect on FSH signal. So you have to supplement myoinositol because in fact, some people prefer to give only myoinositol instead of DCI. But if you give it in a proper ratio, the function of ovaries will improve, the egg quality improves, and then, the reproductive function also improves. Next. So like I said, the physiological ratio in blood is 40:1. So that is what everyone prefers to give. Has allowed ovaries to return to their histological characteristics, improves the LDL, HDL, and triglyceride levels, reduces fasting and circulating insulin levels, improves oocyte quality. Because these also can reduce the insulin resistance. It is not only berberine, it is also myoinositol and D-keroinositol. These are all nutraceuticals, because myoinositol is a naturally occurring product. It is a type of sugar. Next. So what happens, the advantage of adding other nutraceutical supplements into PCOS management? CoQ10 is again, it is an enzyme which improves the mitochondrial function. So the oxidative stress is relieved by CoQ10. It's a coenzyme Q10. It protects ovaries from oxidative damage and improves insulin resistance, increasing FSH and reducing testosterone and improving blood lipids. So this is an antioxidant which improves the mitochondrial function. That is the energy source in the cell. We all know the mitochondria. Next. So vitamin D, again, now we want, one thing we all must remember, in PCOS women, the level of vitamin D is very, very low. We have done tests, we have done studies, and we have found that vitamin D as such is very low in our women, and in PCOS women more so. 67 to 85% of PCOS patients have concomitant vitamin deficiency. So what happens? Unless vitamin D is there, calcium cannot be absorbed. So there is a low BMD. osteoporosis. And then, it is supposed to, now people say it is a pro-hormone. It is not a vitamin at all. It's a pro-hormone. So hirsutism, hyperandrogenism is resolved. Elevated, if it is deficient, there is elevated cardiovascular disease, ovulatory dysfunction, menstrual irregularities. And again, vitamin D is supposed to improve the supplementation, improve the insulin resistance. So many naturally occurring things which can improve the insulin resistance. So supplementation of vitamin D, who are deficient, at the same time, we should not increase the dosage of vitamin D because hypervitaminosis has its own problems. So it improves bone health, improves menstrual regularity, improves lipid profile, and again insulin resistance and body mass index, reduces the cardiovascular risk. Again, methylfolate, like I said, methylfolate, B12 and B6. These are all required in the metabolism where, the methylation occurs in almost all the coenzymes. That we must remember. So these are important, and if these are deficient, the homocysteine goes up. Once the homocysteine goes up, the vascular epithelium gets affected. That is how hypertension can happen and cardiovascular disease can occur. And already PCOS women are obese. So if there is a deficiency and you are giving metformin, there is a B12 deficiency. So you will have to add methylfolate also, which decreases the homocysteine level. Next. Chromium picolate, again is an essential element in metabolism of glucose, insulin, and lipids. And it has shown there is a beneficial effect in decreasing BMI, fasting insulin, and free testosterone. Next. So a combination of all these nutraceuticals can help us. That doesn't mean that we are giving up metformin anytime soon. But where a woman cannot tolerate metformin, we have this. The only problem with this combination of these nutraceuticals is it costs more, and it can also cause some side effects like bloating and other things. But they have a better action, much safer than metformin in the side effects profile. Thank you very much. So any questions in the chat box we can take now.
Just a second, ma'am. I will check in the chat box if there are any questions. So I don't think so, ma'am, there are any questions, but I have the few ones like how much time it takes to observe improvements in patients with PMS when you prescribe EPO, like in 10 days?
Minimum 3 months, minimum 3 months. So you have to continue the medication for 3 months.
So there is no stoppage, like when menses come, you don't stop it, like
No.
continue.
Every day you give.
And do you require to change the medication over time? Like if it's not responding in 2 months, so you change something or add something?
See, mostly, we add a psychiatric drug, like I said, SSRIs, mostly. Otherwise, we give only evening primrose oil, and with the vitamin E, that is the tocotrienol, we give. And sometimes we may add vitamin B6.
Okay, ma'am. And do all PMS or cyclical mesalgia patients need treatment, or at the level of starting, you start counseling and then prescribe a medication?
No, the first thing is, like I said, like in the RCOG criteria, if they are mild, you need not treat. You can just counsel and tell them to have lifestyle changes. But where they are really causing debilitation and then their quality of life is being affected, definitely you will have to treat that.
Then coming on to like PCOS management, like metformin, and there is a OC pills kind of thing, which is majorly prescribed in PCOS management. Do they cater all the symptoms of this PCOS, like irregular menses? If metformin is prescribed,
See, the problem in PCOS is, like I said, lifestyle changes are very important. So even there are two types, obese PCOS, thin PCOS. See, even in a thin PCOS, the visceral adipose tissue is very high. In our women, especially, Indian women, South Asian women. So they have to exercise, they have to follow a dietary pattern. So lifestyle changes are very, very important. Apart from lifestyle changes, we add drugs. Now, medication, what are we doing in PCOS? We are treating whatever problem they have. Suppose they have irregular menses, we give them COCs, depending upon what type of COC they want. Suppose they have irregular menses along with the unwanted hair, hirsutism, then we add a progesterone which is highly anti-androgenic. You understand? Suppose they have reproductive problems, they are not able to conceive, then we have to go in for ovulation induction.
Yes.
Mind you, in all these women, lifestyle changes are common. You have to follow that apart from this. And if it's only a cosmetic problem, you are anti-androgens like aldosterone, which you give for 50 milligrams. But you have to tell them when you give the anti-androgens,
Right.
there can be a irregular periods. So maybe you will add on COC along with this aldosterone, and you tell them that this is only temporary. And then, once they leave, because unless they lose weight, their hyperandrogenism is not going to come down. And the most important thing in PCOS is counseling them about the long-term effects of PCOS, like metabolic dysfunction and the risk of endometrial malignancy. And with obesity, we all know that there is an increased risk of breast malignancy also. So in these women, we have to tell them your lifestyle management is lifelong. That we have to impress on them, because unless we impress on them this, which is very difficult to maintain, it's going to be very difficult to manage PCOS.
So basically, it's kind of a symptom management more than managing insulin resistance or hyperandrogenism. It's a bit.
Because these people are more prone for type 2 diabetes also.
Yes.
Like I said, metabolic dysfunction, So there is an increase in fasting glucose. So you'll have to tell them these are all the problems you have to face. So if you want to postpone, it is not that they will not give diabetes if they follow lifestyle changes. In spite of that, they'll get, but you are postponing it a little away, and then you'll have to get treated for those particular things.
So, ma'am, in both these conditions, how good is the compliance to treatment, and what do you do to ensure that the compliance is better with the patients to the treatment?
The counseling, the counseling is an ongoing process. You just can't think of counseling them once and then think that they are going to stick to the treatment or continue with the treatment. What happens mainly is, when they are adolescents, they come to us for cosmetic problems or the menstrual problems which the mothers bring. And one more thing, which we have noticed, I'm sure all the gynecologists have noticed, is very difficult to maintain weight. People don't follow diet and exercise regimen continuously. Very difficult to maintain. So what happens, they give it up and then, they get married, then again come back to us for reproductive problems. Then, in the reproductive problem, once they conceive, they are high risk pregnancies because they can become diabetic. Gestational diabetes is very common in these women, as also gestational hypertension and preeclampsia is also very common. And like our Government of India management guidelines says metformin is the first choice. But metformin comes again with its own problems, like it can cause growth restriction. Though it is said that it can cause preterm labor, which I don't find so much, but there can be a little growth restriction. So again, after the reproduction is finished, they become diabetic. And then they go in for metabolic dysfunction. So you have to treat them, treat those conditions also. And the post-menopause women, the malignancies, especially apart from the metabolic dysfunction, they can have endometrial carcinoma also. So these are all the things which are we are looking at and managing. And like I said, ongoing counseling is a must for these women. And so much of awareness we have to bring in these women. And that is why I said there are the latest guidelines which have been brought in by Helen Mead, It's very good if you go through it literally. But how many patients are going to follow this? That is the $1 million question.
So basically, a lifestyle
Ma'am,
management is the core Ma'am, as you said that malignancy can happen in the later stage. So there are any test or recommendation like when woman reaches to 40 with PCOS? So
See,
there
we
are
all say it's like a well baby clinic. We have a well woman clinic also. No? So every year they are supposed to come, but how many women really come to us? Once a year they're supposed to come, except when they are in central government service or multinationals, where it is mandatory for them to go for a yearly checkup, master checkup. Then, they'll go there and then once they find something wrong, they come to us. But an ordinary woman, they don't do it. That's the
yes,
problem.
sure.
So, ma'am, how good is the acceptability of nutraceuticals in both these conditions by the patient?
The problem is that first the gynecologists have to accept it. And then the patients will automatically accept, isn't it? See, the moment you prescribe metformin, the parents are worried. Like I said, when we prescribe COCs also, they are worried. The parents are worried because they are worried because we are giving some pills, to prevent pregnancy. They don't understand that COCs are not only for preventing pregnancy, but for the other things also. That's the problem. So counseling goes a long way, and seeing that the patients stick to the treatment, that is becoming a big problem. They don't stick to the treatment. They give it up after some time. How many people come back when we tell them you come back after 6 months for a review? They come back only when they have a problem. They don't come back every 6 months. That's the problem.
Okay, ma'am. Sure, ma'am. So berberine, apart from cost, how do you see in the PCOS management? Like,
It has good as long as insulin resistance is being improved. I think it's a good nutraceutical molecule.
sure, ma'am. Manish sir, do you have any other questions?
No, because we can close this meeting. Thanks.
Thanks, ma'am. I think you have wonderfully answered all my questions, and it was a long question answer session. So sorry for that after a 1 hour
No
talk.
problem. No
Yeah,
problem.
yeah. So I would like to take a moment to reflect on the valuable insights shared by you, ma'am, and thanks for your exceptional talk on today's important topics, including PMS, nostalgia, and the PCOS management. Uh, so a special thanks to you for your outstanding presentation, which provided the invaluable insights into the role and efficacy of EPO in managing PMS and nostalgia. So sharing just a few thoughts about the EPO and the brand. So like for over 3 decades, EPO has been a trusted treatment choice among the gynecologists for management of PCOS and nostalgia. And notably, a Primosa, a brand containing evening primrose oil, is widely recommended in medical textbooks. You also shedded lights on promising natural treatment, which is nowadays commonly used in Europe and English-speaking countries. That is berberine for PCOS management, and Universal NutriScience is proud to be the first to introduce these solutions in India. And with the support of esteemed professionals like you and other gynecologists, Universal NutriScience is committed to uphold the legacy of Primosa and advancing women health through innovative solutions like berberine. And we have recently also introduced Vitus Agnes Castors for irregular menses, which is also a safe treatment option to manage irregular menses. And I would also like to express my appreciation to Ms. Priya Chauhan and the Women's Health Marketing team for organizing this insightful webinar series. A big thank you to RX Events also for the seamless event management and to all the participants and contributors for making this webinar a success. So once again, thank you to you, ma'am, and
Thank you. Thank you.
just over to you. Thanks, ma'am.
Thanks a lot and good night.
Good night. Thank
Thanks a lot, madam. Thank you very much.
thank
Good
you, ma'am.
night, madam.
Thank you for
Thank
taking out
you.
your time and giving this presentation. Thank you so much.